Okay. So, good evening and welcome back to the Lipid Panel. My name is Dr. Ann Carol Goldberg. I am the co-chair of programming for the Lipid Panel, working with Dr. Dan Soffer and Brittany Thompson. The Lipid Panel was conceived to be a lipid clinic conference on a national scale. For those of us lucky enough to have in-house colleagues, Lipid Clinic Conference is a great way to debrief after a busy clinic, to review diagnostic approaches, how to interpret clinical findings, and generate therapeutic strategies, and to come together with colleagues. For the rest of us who feel like we are on lipid islands, conferences like this remind us that we are not alone. If you have cases that you want to be presented at future conferences, please email Brittany at bthompson@lipid.org with your suggestions. In this series, we will review common presentations of rare diseases, atypical presentations of common conditions, sometimes even common presentations of common conditions. And we will try to cover important clinical topics every lipid specialist needs to know. This series is meant to be a monthly coming together of rising stars like MNLA lipid scholars and early career lipid specialists, along with more experienced colleagues. Look for our scheduled posting for the final Tuesday of every month. This will be our last lipid panel for the summer until we resume in September. This evening, I'm joined by a superb panel. Dr. Parissa Salemi is a pediatric endocrinologist on faculty at Cohen Children's Medical Center of Northwell Health in New York, where she is the fellowship program director and director of research for her division. In addition to her pediatric endocrine practice, she has developed and heads the pediatric lipid program at CCMC. Dr. Salemi completed her medical training at New York College of Osteopathic Medicine, completed her residency at NYU Langone at Winthrop, and did her fellowship at Johns Hopkins Hospital. Dr. Dan Soffer will moderate the program, and our panelists include Ms. Lauren Williams and Dr. Don Wilson. Dr. Wilson is the endowed chair, Pediatric Cardiovascular Health and Risk Prevention in Pediatric Endocrinology and Diabetes at Cook Children's Medical Center in Fort Worth, Texas. He is an accomplished author and clinician educator. Ms. Williams is a clinical dietitian who cares for children and adolescents with inherited and acquired lipid disorders at Baylor Scott and White's McLean Children's Medical Center in Temple, Texas. She received her Bachelor of Science in Biomedical Science from Texas A&M University and a Master of Clinical Nutrition at UT Southwestern in Dallas, Texas. In a minute, I will turn over the direction of this program to our moderator, Dr. Dan Soffer. Dr. Soffer is an internist in primary care and director of clinical lipidology at the University of Pennsylvania Health System. He is co-chair of the lipid panel with me and is the current president of the National Lipid Association. Welcome all to the lipid panel. Dr. Soffer, it's all yours.
Thank you, Ann. I appreciate that introduction. I will say that I'm the lone adult medicine specialist on the call, and so we specifically put an adult medicine specialist as the moderator this evening to maintain a reliable degree of ignorance when talking about adolescent care, so that I can ask all of the questions that come up that you guys take for granted. But without further ado, I turn you over to our presenter, Parissa Salemi.
Thank you so much, Dan, and thank you so much for the invitation and the privilege of being able to present this interesting case to the audience today. And I look forward to an exciting discussion so that we can all learn together. So without any further ado, I'd like to present this case. This is a common one that we see referred to our office, but this is a 14-year-old obese non-Hispanic white female that was referred to us for dyslipidemia. She was diagnosed with type 1 diabetes when she was 11 years old. This was confirmed via GAD65 and islet antigen 2 autoantibody testing. Her presenting hemoglobin A1C was 8.5%. In addition,
Parissa, before you continue,
yeah.
I should warn everyone. I reserve the right to interrupt at any time and ask all the stupid questions. So for those of us non-endocrinologists, can you just remind us what GAD65 and IA2 positive means?
Yeah, so well, GAD65 just, stands for glutamic acid decarboxylase 65 antibody. And, the IA2, again, islet antigen 2, are one of a couple or several different autoantibodies that are tested to confirm it, to make a diagnosis of an autoimmune type 1 diabetes. The other ones include insulin antibodies or zinc transporter antibodies. And if we see any one of these that are positive, it's a confirmatory diagnosis of autoimmune type 1 diabetes.
Thank you.
So, so it's not too uncommon in our pediatric endocrinology practice to see individuals who've been diagnosed with type 1 diabetes to also present with depression. This patient, has been experiencing some depression for some time now and has been seeing a therapist weekly. Again, not too surprising, once again, in our adolescent population, there has been a history of non-compliance with the diabetes care, specifically the insulin administration.
Parissa, do you feel like you see a lot of obese type 1 diabetics? That's not the image I have in mind when I think of adolescent type 1 diabetics.
Well, sure. Typically, we think of type 2 as being more overweight and, needing lifestyle modification, and type 1 are generally slimmer individuals, especially, in the early years. But it's not uncommon to see, individuals that may weigh more and also have type 1 diabetes. So we can't just look at weight as a factor in determining that. But while it is still more common in the slimmer population, you certainly can see it in the overweight population.
Yeah, I don't want to sidetrack too much on that, but Don, do you know off the top of your head, is the distribution of obesity the same in the type 1 population as it is in the general population?
No, I don't think so. I mean, you have far fewer individuals who have this type of phenotype, but as was pointed out, and now the American Diabetes Association includes antibody testing because we do see this type 2 phenotype. But as everyone knows, you have to know kind of what the therapeutic options are. So if these individuals are really antibody mediated autoimmune disease, then you kind of pretty much know what you have to do and how you have to do it. But I mean, the bottom line is that, about 30% of kids are overweight or obese, about 60% adults. And so you just see an overlap here.
Yeah. And you mentioned something about used to, or didn't used to see that type 2 in pediatric population. I think I'm old enough, and Don, I'm guessing you are too, to remember that MODY as a rare disorder. And
well, actually, that's a good question because the last patient I just saw for FH actually had MODY, and once you treat the diabetes, that it just melts down. So I think the challenge here is to actually make sure that you do enough diagnostic testing to know what the patient has and what they don't have. And that's kind of the point the American Diabetes Association is making. Back in the 70s and 80s, type 2 diabetes was basically age driven. So you didn't see anybody under the age of 40 that we knew that had diabetes. Now, were we not looking? I think we're pretty good at it, but we probably did have some kids that we didn't identify as type 2. So we just kind of lumped them all together. In fact, I had a large Native American population in Oklahoma. I'm sure in retrospect, a lot of those kids have type 2 diabetes. So I think it's important because it does help in terms of driving the conversation about what can we do therapeutically, what are the options for these people. And as we'll talk about, there's significant difference in the morbidity in children in type 1 and type 2.
So I actually have another question that's sort of from the eyes of someone who's been in practice a while. I really like that we call it type 1 and type 2 now, as opposed to insulin dependent and non-insulin dependent diabetes. And I think that it's really critical that we think about it in those terms. I presume in a pediatric endocrinology clinic, you think about it not just in terms of whether they require insulin to prevent ketosis, but what their endogenous insulin might be. And is that right, Parissa?
Yeah, no, absolutely. I mean, we have many patients with type 2 diabetes that are on insulin, so we can't really say, that type 2 diabetes just, equates to oral glycemics alone. So certainly not. Yeah.
Well, the other thing to keep in mind, Dan, is that many of the at least the children, I suspect is true in the adult world as well, is that since patients with type 2 tend to develop apoptosis of the beta cells, even though they start off with a classic insulin resistance, dysregulated insulin secretion, many of these individuals will actually become insulin deficient. And so you have to kind of change strategies then, because now they've become insulin dependent, even though they have, quote, type 2 diabetes. So it's, the definitions of type 1, I agree with you. I don't think that the old terminology of sort of non-insulin dependent and so forth really helps, but you have to understand the underlying etiology and then the time course, how this plays out.
And I know we're going to get into this, Lauren, but in terms of when someone finds their way into the dietitian's room during the visit who's labeled as type 1, but who, as soon as they walk in the room, you're thinking to yourself, boy, I bet there's a fair amount of insulin resistance going on here. I imagine you're already sort of rerouting how you're going to be planning your session. I mean, I know you don't want to be biased going into it, and you want to take in information, but am I right that you're already starting to think about a different approach to the dietary counseling? It's not just straight carb counting and that kind of thing.
Right. In my opinion, it actually makes it a little bit more complicated and more complex for the family. And maybe I would think that it would be better to take it in steps. And so the carb counting, of course, is going to be first and foremost. I mean, that's the main part of the education that you want for them to get, because they're going to be dosing insulin and everything. And so for safety purposes, you need to teach them carb counting first. And then on the backside of things, once they kind of get a hold of that, making it more approachable to talk about maybe portion sizes or setting carb limits if needed per meal. But carb counting first and foremost, but then also talking about kind of the healthy eating components and making sure they're exercising and everything on the back end as well.
Great. So Parissa, I think we made it to page 2.
Yeah, no, we did. And I was about to start asking Lauren my next questions, but I said, I'm going to pause and save it for later so we could get through page 2. So this patient was on a classic basal bolus regimen, which consisted of Lantus, the long-acting insulin of 37 units at bedtime, and mealtime insulin of Humalog, 1 unit per 7 grams of carbohydrates with a correction factor of 1 unit for every 25 glucose points above target. So as Lauren will teach us a lot about this, but this patient is on a carbohydrate counting diet, which is very important for optimal glycemic control of a patient with type 1 diabetes. The social history was.
So I do have to just interject because, again, I think everyone on this call is very used to this concept, but I can tell you that when taking care of adults, if you're not an endocrinologist and you're not taking care of type 1 diabetics, the concept of carbohydrate counting is a very foreign concept. And maybe Lauren, can you give us just a primer on that?
Absolutely, I'd be happy to. So whenever we're teaching, especially pediatric patients, carb counting, they're taught to count total carbohydrates first and foremost. So we're not talking about net carbs that you see on all the packaging these days. So counting total carbohydrates and looking at food labels. So we teach food label reading. We teach the food groups that contain carbohydrates. So it's going to be your dairy products and your starches and grains, your fruits, starchy vegetables, all of those, your packaged processed foods, sweets and desserts, all of that. And so teaching the patient and family, so including the patient as well, especially if they are preteen, teenage years, they need to learn the carb counting as well. So teaching them the food groups that have carbs, the label reading, and then also having them practice in the room too. So really important, especially on a somewhat low ratio. So the 1:7 or 1:5 or any of those low ratios, it's really important for them to learn how to count every single carbohydrate and practice with the medical staff that's helping them out. I don't know how in-depth you want for me to go. But
let me add one other comment to that. In addition to the carbohydrate counting, you just simply have to make sure that they can count, period. You have to practice the math steps. So if you think about it, 1 to 10 should be fairly easy. You just divide by everything by 10. But when we kind of get fancy with it, we say, okay, we want to do a ratio of 1:7, 1:5. Then you got to have a conversation about, okay, how are you going to do that? It's okay to use a calculator, you have them on your phones, whatever it takes, but don't make the assumptions that kids could necessarily count correctly and or do the math.
And not only kids, but adults. Fractions are
Yes.
hard for a lot of people. And so whenever you say, great, you're going to eat, you know, say you ate 2/3 of your sandwich and each of the pieces of bread had 15 grams. So that's 30. So what's 2/3 of 30? And their eyes glaze over. You know, that's a part of the education you're going to need to revisit later on.
Right. And I'm sure, you know, Lauren, I'm sure one of the most important tools that you show a lot of the patients and their families are all the apps that they have now to help with those calculations. So you can just enter, you know, I ate 36 grams of carbs, and it will tell you, it'll spit out, okay, that's going to be X amount of, you know, units of insulin, right?
Yes, absolutely.
I think this
Absolutely
is
correct.
important. It's not only teaching the concepts when many people can get, also exploring the tools that people need in order to be able to implement. Let's not also forget that some of our parents are illiterate. And so the reason I'm bringing this up is because we have a lot of written material that we're very proud of. It's very colorful and so forth. But many adults, at least in my experience, who are illiterate, have a lot of pride. And so it takes 3 or 4 visits before you figure out you got to help them a different way. And the ABA and others have a lot of information about how you deal with illiteracy. So just have to kind of ferret these out in the first, first couple of exams.
Yes. And also eating out too. So making sure that they do have apps on their phone that, or know how to access the nutrition information for different restaurants or places that they're usually going. And then I found it helpful in the past too, and I'm sure that you all have found it helpful in your clinics as well. If they have places that they're regularly going, things that they're always ordering, things that their family is always cooking, finding an app where you can have a recipe builder to where you can put in all of the different ingredients in the recipe and it spits out a semblance of a food label for them, so that, you know, if grandma is always cooking and she always cooks this one dish, then you know how many grams of carbs are in each serving of that. And so really giving them the tools in their toolbox to be able to go forth and be successful with things that they're usually eating.
And, you know, I'm always,
otherwise you're asking them to go cold turkey.
Right. And I'm always so, yeah, I'm always so impressed by, you know, how much you need to know when I look at Calorie King. It's the app that has the list of all of the calories and the carbohydrate content, all the different contents of the foods, because, you know, if you go to TGI Fridays, you don't want to think about how many calories are in, you know, the chicken fingers, or if you go to Outback, the blooming onion. But guess what? You know, when you have diabetes and you have to carb count, you actually have to think about how much of this serving am I having? How many grams of carbohydrates is that? And it's daunting. It's daunting. So, you know, to have every single food item in this app, every single restaurant, to kind of find it and then to see what those numbers are, you know, it's very impressive to have to learn all that.
And I would say, especially for those that are struggling with overweight or obesity, it can be even more overwhelming, because whenever they look up information online, they're hearing about the ketogenic diet and the paleo diet. I had somebody today say the primal diet. And so, you know, they're hearing about all of these things because in their mind, as a preteen and teenager, they may be more focused on the weight issue. And so they're hearing about all these different ways to lose weight. And so then they come to us and say, well, I hear that you should really just be counting net carbs and I'm doing the keto diet, when really you have to re-educate that, no, we're dosing insulin based on total carbohydrates and all of that, depending on the practice that they're in. And so there can be a lot of nutrition noise out there that can be very hard, especially for a patient like this that has depression as well.
Yeah, we'll get back to the specific type of diet for sure. So let's put a pin in that aspect, because I definitely have a lot of questions about that, but I'll leave this to Parissa to carry on from here.
Yeah. So, you know, as with any adolescent teen, we always take a few moments and speak to them privately, you know, and, you know, tell them that they can confide in us and tell us anything, as long as, of course, they don't want to harm themselves or anyone else. And, you know, she did state that she, you know, is not using any alcohol, drugs, or tobacco, and she's not, and nor has she ever been sexually active. She lives with both parents and her 9-year-old sister. So she really didn't specify, anything so much about, her mood, but she does admit to, being depressed, as we said earlier. Menstrual history, her menarche began at 12 years of age. In general, it has been irregular, and she's had some mild dysmenorrhea. There's been no history of hirsutism or use of oral contraceptive pills.
So just keep in mind that this is an adolescent, and just like any adolescent, that's self-reported information.
Right.
And
So key thing of what they...
It may or may not turn out to be true, but just keep it. We want to certainly give everybody the benefit of the doubt. But
right, which is why, it's interesting, and that's why I say, I tell them this is being, you're confiding in me, legally I can't share this with, your family members, this, that, or other, but it takes quite a bit of trust to be able to, tell your doctor things that, you find to be very private, especially for a young adolescent. So this is what they say, and you don't always know the truth, right?
And the other thing is, we all know, I mean, they just met you. This child just met you, right? You're a complete stranger to them. You have no credibility nor trust. But I can't tell you how many times that history of irregular menstrual periods turned out to be pregnancy, despite the fact that there was no sexual activity. So maybe that definition is different in the mind of the child, but the reality is, we want to try to help here. So you have to build that trust.
Absolutely.
And it also depends on who they're talking to in the visit too. So that's one of my favorite parts about a multidisciplinary clinic, is it seems like with each person that goes into the room, you get different pieces of that puzzle that then you can all come together at the end. And inevitably there's one team member. I mean, Dr. Wilson, how many times has this happened whenever I was in the Reach clinic with you? But there's inevitably that one team member that says, that's not the story that I got. And then you can really kind of put it all together.
I don't want to go down this rabbit hole too much, but I am curious whether any of you think that there would be any value in doing some fact finding on this using laboratory tests, like tox screens, substance exposure screens, even PEth level, ethanol level,
But then we typically do that in adolescents when they come in DKA, not necessarily the first episode when they're diagnosed, but repetitive episodes. On the other hand, I wouldn't personally do it here because it destroys credibility. Mm-hmm. So if this child thinks that I'm going to do a pregnancy test every time I'm concerned that she might be pregnant, then there's not going to be any trust whatsoever. So yeah. I would give her the benefit of the doubt until I found out otherwise. But great question.
And again, don't need to get too into this, but the menstrual periods will throw the blood sugar bit out of whack during the period, right? So you have to adjust the insulin level during the period a bit.
Oftentimes, yes, and they usually, notice that trend themselves. And let's say they're on a pump, they may have a different basal rate during times that they're, menstruating versus times they're not, or maybe they're instructed to take, different amounts of Lantus, during that time period. So, at some point they get to know their own patterns, but, absolutely.
But here, one of the things I think we can, take solace in is she's not taking an oral contraceptive, other contraceptive methods. So that has a relevance in terms of when you start looking at the labs, you have to kind of factor in women and OCP and what kind of effects that has on dyslipidemia and so forth.
Right.
Great. All right.
Okay. So the family history, of course, is quite important. There is a mixed family history here. So we have mom who's 45 years old. She has vitiligo and multiple sclerosis. So certainly, an autoimmune history on mom's side of the family. Father, he's 47 years old. He's on some medications for hypertension, for type 2 diabetes, and hyperlipidemia. The exact medications at the time were not known. Paternal grandfather had a non-fatal MI at age 53 years, and subsequent to this had 4 stents placed.
Does a family history of vitiligo and multiple sclerosis associate with type 1 diabetes?
Certainly the vitiligo does. You see a lot of parents that we usually put this out to medical students or residents. Mom's sitting there with a lot of vitiligo and the child actually has type 1 diabetes, but there's more than a coincidence, yes. Sometimes the child will actually have vitiligo with it.
And I guess, having a father who has type 2 diabetes already puts her at greater risk for developing insulin resistance, leading down that pathway, even if she didn't have the type 1 diabetes.
Yeah, and I don't know what you guys experience in adult medicine, but this is actually quite good for a pediatric family history. It's not very detailed in terms of, a lot of the information you'd like to know, but this is much more than we usually get.
Yeah. So, what I think is interesting that, this may suggest, again, sometimes they don't know the family member's height or weight and their perception of, are they overweight? Are they average? They may say average, but then maybe learn later it's really not average. It's, perspective is different from fact. But, what I think that, it could be suggestive of is, and, Lauren, I'm sure you could chime in on this, is, a lot of weight gain is environmental. Some of it is genetic. And you wonder, maybe the father having type 2 diabetes, does he have poor eating habits? Is he, quite obese? And, has he kind of brought in, certain components of his diet into the household that have led this individual who may have an autoimmune predilection, but yet is learning to eat like someone who, is a 6 foot, 280-pound guy. So I think that's kind of interesting to, get a glimpse of what the environment may be for the diet.
I think that's a really great point. And I think it's also important to realize two things. One, this family probably in terms of nutrition has gotten a lot of information, probably from a lot of different people, different doctors, maybe a couple dietitians. And it gets harder and harder for an entire family to eat one thing, the more stipulations that there are. So now this family not only has probably the DASH diet or some semblance of sodium restriction or whatever for the hypertension, but then also now has reduced carbohydrates, presumably for type 2 diabetes. However, the number one thing that I hear is, oh, well, dad and grandpa and everybody have type 2. And so we know like we're supposed to do everything sugar-free. Well, then you have to go back and teach the sugar-free items may actually have more total carbohydrates than the regular. So let's, not sugar-free for this person who has type 1. So, but then also on top of that, with the hyperlipidemia, they may have been taught about different healthy fats, et cetera. So they have a lot of information that's been thrown at them medically, and it may be difficult to discern what in particular is important for this one patient.
Yeah.
The other things worth pointing out, but I think most people who take care of children understand this, but if you look at that family history, the question sort of becomes, okay, so who is actually parenting the child and what time frame do they have to do this? And sort of what are the concerns and what are the finances in this family? Because look at mom's multiple sclerosis. I mean, we know how that disease waxes and wanes over time. Might this child's depression, for example, be related to her family history or specifically to her mother, who she sees having these issues? But multiple sclerosis, the father's illnesses are going to be fairly expensive just from a crash standpoint. So, how is this going to work in terms of what kind of insurance does the child have? What kind of medications can they afford? What about the food? How do they eat? Do they have family time together? Or who's the confidant? Who does the child go to? So a lot of the first couple of visits are sort of consumed trying to get to know the family dynamic. What do these people do for a living, right? Is it a stable job? Obviously, the mother may or may not be able to work. Did they just start a family business? Then as far as a child, what do you do in your off time? What do you like to do for fun? Do you have friends? What do you do with your friends at school? Are you a social media person? All those kind of questions, but it just takes a lot of time to get to know people. But I think it's the right thing to do.
Yeah, and Don, I think you bring up a good point, because now that I'm thinking of it, when you put yourself in someone else's shoes, let's say mom, is more fatigued certain days, she's not able to conduct her routine. Let's say she's at home and she has certain like household chores she may do, or maybe she's the one that would customarily prepare foods or do the food shopping. And there's a 9-year-old younger sister. Is she taking on the role of the, parent for the 9-year-old while maybe, dad is out, and, is dad's idea of, dinner kind of stopping off and, getting, burgers for everyone somewhere because it's fast, it's affordable, right? So that's so interesting to think about that sort of, how that complex, social dynamic really lends to, the diet and the
right. But you know very well what that real conversation is about in the 9-year-old is sticking in her sister's face saying, well, we could do all these things, or we could afford to go on vacations if you didn't have diabetes and we're consuming so much time and resources. Or we wouldn't have to eat this way and we wouldn't have to do all these things, if only if you didn't have all these things. So you have to kind of understand those dynamics, because that's really where these people live.
Yeah,
And also too, who's giving this child her insulin? Who's helping her to count carbs? Are the parents able to? So, with non-adherence to medication, is it from a lack of want and try, or is it from I'm 14 and I'm scared that I'm gonna give myself too much insulin because I've heard that can be really bad and mom's not able to double check my math for me? And so all of those things are important.
Yeah, and also just the whole, what you mentioned about, the expense or, the weight of this disease. I think, it's important to point out how, type 1 diabetes or diabetes really takes a toll on a family unit, because it's not a disease that anyone could get away from for many hours. You can't even get away from it for 8 hours, really, because it's something that you're constantly having to address and treat.
Well, the other thing is that, this mother in particular, so let's assume that the dad has a job, but he could be a truck driver. He's gone 5 days out of the week. Who takes care of the mom when she has an episode, right? Is it this child's responsibility because she's the oldest? And she expected to take care of the other children when the mother has an illness? So all those things become very, very important. The other thing that, we'd like to know something about this child's school performance. How well is she doing in school? You'd expect, given what we're given, is that she may be struggling. And so, those are important social markers. So what you really like to hear is this child has a circle of friends. They get together and giggle at lunchtime and do silly things. And she's watching, she does TikTok or whatever they do these days. But that's kind of normal adolescent behavior, as opposed to sitting in a room and being isolated.
I appreciate all those concerns. I'm going to put one more thing in the pediatrician's lap. So I take care of Grandpa here. And I remember when he had his myocardial infarction, and I'm not sure whether his son ever came in to come see me. Don't know where his son's getting his care. And his son is right around the age where Grandpa had his heart attack. Now the granddaughter is in your room, and this history. Do you see this as an opportunity to make sure Dad is getting the care he needs? Because he strikes me as a ticking time bomb himself, and you're poised in a position to really make some headway with education there.
So then, as part of exploring the family dynamics and the finances and talking a little bit about the health of the family and the healthcare belief system, we also talk about the family members, particularly those who have diabetes, as being role models. So, somehow when you get to know these people, you sort of say, well, tell me a little bit about your own diabetes. How are you taking care of yourself? How well is that working for you? And that sort of thing. And then the obvious implication or frank discussion is, realize that your daughter is actually looking at your behavior. So if you're not checking your blood sugars or taking medication, chances are she's not going to be doing it. So yes, it's very important. The other thing is, because these conversations will, out of necessity, include morbidity and then mortality. We talk about cardiovascular disease or heart attacks, particularly in our FH. You have to be very careful with those conversations in front of a teenager, because this grandfather had a non-fatal, fortunately, MI, but they fast forward to thinking they're going to have an MI tomorrow. They get the same thing as the family member, in this case, FH. What they heard was they're going to have a heart attack before they get a chance to graduate high school.
Yeah, all I was thinking was might be nice to whisper in his ear, hey, I hope you're taking statins and maybe an aspirin too.
Well, I think most of us have had the experience where parents actually some parents, not all, but some of them actually step up and do a much better job with their own.
Yeah. And I agree, Dan. I think it's a great opportunity that I always try and take advantage of, that when I hear this, I always say, she's my patient, but you're her mom, you're her dad, and I need to know you're okay in order to take care of her. And I absolutely take advantage of that. And I probe and I ask them, okay, well, what medications are you on? Do you know what your cholesterol was? They'll say, no, I don't. I say, do you have your access to your, portal? Can you see? Because, sometimes they start to grow that new concern for themselves through the eyes of their children, because parents are always worried about their children at the expense of themselves oftentimes. And then when you're able to kind of show them that, listen, this is the concern I have for your child, but what about you? You said sometimes, Don just said that it's an opportunity where they rise to the challenge and really, try to set that example for their child.
Yeah, the other not so subtle question you can ask of the 14-year-old is, on a weekend, what do you and your parents do? What do you like to do with your father? Now that's an open-ended question, right? And you're going to get probably a no answer. The same thing
a 14-year-old?
Sorry?
From a 14-year-old?
Yeah, because what it means is that anything together. You can also ask the father as an informational item, what do you like to do with your daughter? And see if they can come up with an answer. Right now, if he says, oh, we go on bike rides, or we sometimes go to the beach, or I take her to the pool, that's great. But a lot of times the answer is, I don't have time for that.
And I don't know about you all, but I always like to ask very specific patient questions to my patient, because if you ask a parent, like, what does she eat in the morning or whatever, they kind of know the right answers sometimes, right? Like, oh, it's always this, this, and this. But when you ask a child, sometimes some of these questions, it's a little bit more unfiltered. It could just be more like, oh, I don't really do much on the weekend. I sit around, watch TV. They'll say it the way it is, versus a parent doesn't want to make it seem as though they're not, trying to encourage, more activities in their child. So I say, oh no, she goes, to her friend's house. She does this. And so I always think, to get the different perspectives by first asking, the actual patient, and then also getting the input from the parent is very important, because you need to put the two together, right?
Yeah. All right. Well, let's learn some more about the patient's medical status now that we have dove into her family and all that.
Yeah. So, her vitals were stable. Her heart rate was 78 beats per minute. The blood pressure was 118/78, which is normal for age. Her height is 61 inches, which is between the 10th and 25th percentile. Her weight is 169 pounds, which is greater than the 95th percentile. And her BMI is 31.8 kilograms per meter squared, which is also greater than the 95th percentile. Her physical exam was notable for her having a slightly flat affect. Her neck did show some mild acanthosis nigricans. There was some visceral obesity of the abdomen, and there was no lipohypertrophy or lipoatrophy on the examination of her skin, where she normally would get injections. And the remainder of the exam was within normal limits.
And when you do these exams, do you strip them down to a gown to really, to look at their arm, their axillae and their groin, and to look for other signs of acanthosis, or are you a little more hands off to not make them feel too on the spot?
So, it's a mix of things. I think sometimes, when you see them in the hospital setting, they may be, in a gown, but again, it's a traumatic experience sometimes, and you don't necessarily need to do pubertal staging in an inpatient setting when they're in DKA. However, I do think that, a thorough exam is important. And I don't necessarily always put them in a gown, because I want them to be comfortable. Pediatricians don't wear white coats, oftentimes when entering a room. So I think that, as long as they're wearing something that, allows you to easily look, underneath their arms by, looking, underneath the t-shirt and things like that, it's probably better for your overall, endpoint. Because again, it's scary for a young lady, especially to be sitting in an office and is already in kind of an unfamiliar situation that you don't want to feel like you're exposing them too much. That's kind of how I practice.
Yeah, we never put anybody in a gown unless we need to do the pelvic, and then that's a totally different thing. But the other things that's important, even for young children, more so for younger children, is tell them what you're doing.
Mm-hmm. Yeah.
Never approach a child without asking permission. Can you touch them or listen to their chest? In fact, a lot of young children, they'll actually assist you. So you can ask them where their heart is. They'll put the stethoscope there, and you can kind of ease into the exam. But to answer your question, yes, we do a pretty thorough exam, particularly first time around. Absence of genitalia, unless there's some need to do that.
So, also, I think when you know some of the things you're looking for, it makes it a little bit more, pointed. But for instance, we always feel a thyroid. There isn't a single thyroid that isn't palpated, when it comes into the office. And also, anyone that we see whose weight is on the higher side, we're always looking at the neck, looking for acanthosis. And what's interesting is we certainly note more acanthosis in obese individuals with darker pigmentation, the Black population, Hispanic population, or Latin American, you'll see that. And not often or always, in the white individuals, but in this case, there was some mild acanthosis, which is suggestive of some degree of insulin resistance, so it was kind of interesting that we know she's autoantibody positive, but still there was some, mild cutaneous markers.
By the way, if the only thing you're really interested in is knowing whether this child's in puberty or not, and sometimes that's important, particularly for insulin dosing, or you might think a patient has Moriac syndrome or something like that. You can actually ask the child. In fact, we published a paper where, Tanner staging is 1 through 5. 1's prepubertal, 5's adult, and it just shows a pattern of pubic hair and breast development in females. If you just show them that line drawing, they can actually pick out almost 100% of the time where they are in that process.
Great. Did you have any blood work done?
She did. And segueing to almost the next slide, but first I just wanted to show her BMI pattern. So, again, she presented with type 1 diabetes around 12 years of age, so it was right around this time. She has always had an elevated BMI well above the 95th percentile. The 95th percentile is that darker line on top. And there was a time period where, her BMI did go down, only for it to steadily rise, maybe during the pandemic times. And then, in this approximate, I guess 6-month time interval or so, there had been, somewhat of a decline in her BMI. So going to your question about the labs. So this patient had labs drawn on 2 separate occasions, 6 months apart, and I'll review some of the notable labs. But the total cholesterol when seen, at the baseline visit was 186 milligrams per deciliter, and 6 months later, it rose to 230 milligrams per deciliter. The triglycerides, and this was fasting, was 424, and 6 months later was 940 milligrams per deciliter. So both high so far. The HDL calculated was 31 initially, and 6 months later was 28, fairly similar. The LDL calculated value was unable to be obtained due to the high triglycerides. The non-HDL calculated was 155 at baseline, and 6 months later, 202. The ApoB level was not drawn initially, but at 6 months was 98. And the random glucose, or I guess we could say the initial fasting glucose was 274 at that time, and then 172 6 months later. And the A1C went from 12.7% to 9.8%. We did have liver function tests done, and the ALT and the AST were both elevated at both draws. The initial value for the ALT was 112, which rose to 142 6 months later, and the AST was initially 97, and 6 months later was 118. Thyroid panel was obtained, electrolytes, creatinine, uric acid, all those values were normal for this patient.
So I'm going to ask each of you the same question and see if we get the same answer. And I'll start with Lauren. Lauren, if you're just going to look at 2 numbers on this panel, which are the 2 numbers that you gravitate towards first when the patient comes to you?
My eyes go to the A1C and then the triglycerides, because I am looking at, whenever I'm going to go and talk to the patient, what are we talking about nutrition wise? So how is their glucose control? Predominantly, that's the predominant thought in my head, knowing the diagnoses that she has. But then also, I mean, how can you not look at that triglyceride? And even people that specialize in lipids look at that and go, okay. So those are my 2.
Don, how about you?
So, I mean, I would be focused on the A1C just to get an idea about where she is with the glycemic control. I mean, the good news is it's going down rather than up. So she hadn't figured out that she could actually lose weight by making it go up rather than down. So we don't have to deal with that issue, but a lot of girls would choose that strategy to lose weight. And then I would focus on the non-HDL cholesterol. I like doing ApoB myself. It's kind of not
You're cheating. I gave you two numbers. Now you're throwing in a third one.
No, I'm just saying I like. I didn't say I was choosing it, but the non-HDL is obviously free, and you can calculate that number. But I'm looking kind of for, because this is a fairly atypical pattern for type 1.
So can you just, before we get to Parissa's two readings, can you tell me what you meant by losing weight by not taking the insulin?
Yeah, so most adolescent girls will either figure out themselves, or they'll talk to their friends or look on the internet. They can figure out that if they force diuresis with glucose, so just slack off your insulin, let your glucose rise, you basically have a ketogenic diet. Because you develop ketosis along the way. So you have to kind of take enough insulin to make sure you don't have ketoacidosis, but it's a very effective weight loss tool. And you're foolish, I think, if you go in there and tell this girl that doesn't work.
Yeah.
The answer is it does work. It's not healthy and it's potentially dangerous. That's the conversation you have to have, but it does work. And if the child's primary aim is looking good in front of her friends, that's a hard sell.
Particularly around prom or swimsuit season.
Yes,
We
exactly.
see it. It happens.
And, unfortunately, what you see a lot, especially in this case, is you have a mixed bag of different reasons why you may develop an eating disorder here. You have someone who's overweight and wants to lose weight, and they have type 1 diabetes, so they're insulin dependent. And they learn that maybe, by, allowing for poor glycemic control, that they can, lose weight. But also, here they are, they're fixated on food every single minute of the day, whether it's carb counting, they can't get away from, the thought of food all the time. And, they're kind of damned if they do, they're damned if they don't. If you go in the ketogenic diet as someone with type 1 diabetes, it's very dangerous. But, they're trying to balance everything, which is, glycemic control, their weight, their appearance, all of these sort of things. And it makes it very confusing, which diet strategy are you supposed to use, for your, optimal health, but also happiness. And it's hard to get that all.
So Parissa, in your experience, unfortunately, this child has to take insulin, right? So if we're just focused on weight, what's your experience in terms of the better you control your A1C, the more likely is you to gain weight?
So, that's why I think, people like Lauren have a tough job, because, I certainly think you need to have that balanced diet. But of course, it needs to be limited in terms of the quantity of it, the portion size and, things of that nature. So while you're wanting to optimize the hemoglobin A1C so that the insulin coverage is adequate for your carbohydrate intake and what have you, obviously, if you're overall, there has to be a lot of excess calories in this diet to have reached such an elevated BMI. So it doesn't mean that you can't have healthy portions and have a more balanced meal with more vegetables, the plate method, all of that, and still be successful in having, an optimized hemoglobin A1C, and also kind of, working on that, weight loss goal. But it makes it complex. It's not just one goal, right? It's a few goals for this patient.
So while we have the lipid panel up, and since Don brought up the ApoB issue, I'm going to ask Don to elaborate a little bit more on how you use the ApoB in this particular case.
Well, again, I'd say that, for just our typical type 1 diabetes patients, this is very atypical. Most of them actually have LDL cholesterol levels, for example, that are either just like non-diabetic peers or even less. So this child actually has the phenotype of a type 2. And so if we took out type 1 diabetes out of this equation, nobody on the call that takes care of kids would even bat an eye, right? Even with the triglycerides, because even though, Lauren points out this is startling to most people, that triglycerides will go up and down every visit. So if you took it every day for the next 10 days, you'd see levels that are typically around the 250, 300 range, but they'll spike up. And this one at 6 months could very well be a postprandial, even though she said she fasted. Right?
So that's what I was going to say. Oftentimes, no matter what, they say that they were fasting, and half the time it's not.
Yeah, so I mean, that doesn't bother me as much. So what I'm really looking for, Dan, is what are the risk factors here, and what do we have to deal with? Well, the fact that her ApoB is up and her non-HDL cholesterol is up, you know, she may in fact be a candidate for a statin at some point. The dilemma, of course, is, you know, that's in the adult population about a 10% incidence of diabetes associated with statin therapy. So if you didn't have a child with diabetes, but you had sort of metabolic syndrome and a mild increase in A1C, so they're pre-diabetic, you know, do we put them at risk actually for developing diabetes? Well, the adult literature say, well, they're better off actually on a statin, even though we convert them into a diabetic or child with diabetes. I don't know if that's true with kids this young or not. So it's a dilemma.
Yeah, I mean, I don't see it as a concern amongst adults with type 2 diabetes. They already have type 2 diabetes. They already have pretty severe insulin resistance. You're not changing that very much with the use of a statin. The ApoB itself doesn't look that high here. I maybe compared to what you're used to seeing, it's higher than what you see in a pediatric population, but it's not in a range that we typically see in a, you know, somebody with a very atherogenic lipoprotein profile. This is a relatively normal ApoB and probably disproportionately low compared to the non-HDL cholesterol.
So then the American Diabetes Association for type 2 diabetes in children have a threshold of 77 for the ApoB.
Okay. Yeah. And while we're on the lipids, Nancy Smith wants to, who's on the call tonight, asked whether or not we have concerns about the risk for acute pancreatitis here.
Well, I mean, I think that given this phenotype and the whole scenario of bouncing triglyceride levels and so forth, the answer is yes. That being said, we see some, but it's not in this particular population. It's not been my experience that it's common. Occasionally you see it, but it's not real common. So you warn the families. I mean, you say to them, look, if your child has symptoms of severe abdominal pain, nausea, vomiting, you need to seek help. We actually give them, in our clinic, we give them a little wallet card that says that they have a propensity for hypertriglyceridemia and are at risk for pancreatitis. We ask to show that to the urgent care or emergency physicians, because pediatric emergency rooms are going to think about that, but only after about 12 hours of workup. So they'll eventually get there, but we try to sort of shortchange that. In fact, we try to encourage them to measure the triglycerides in that situation. So, and it could be appendicitis, but at the end of the day, we want them to at least think about the differential diagnosis. So yes, it's potentially a risk, particularly if you ask the father, you know, has he ever had an episode, or family members with that?
And the presence of type 1 diabetes does not in and of itself change the risk for acute pancreatitis in any way?
No.
Okay. Great. And so pretty high triglycerides, high cholesterol too, especially at the 6-month level, with an ApoB that's higher than what the pediatric population is used to seeing. Do you guys think about lipoprotein phenotypes here? Is that something that pediatricians consider? Is it on your mind, like, oh, I want to characterize this patient as a type 4 patient, or are those kinds of thought processes part of what you think of? No, you're just looking straight at the straight numbers.
We don't like to complicate the process, right?
I get that.
One of the reasons for that, Dan, is because this is a changing profile here. So there are a lot of things that need to be done. It's going to be a lot longer than you'd wish to get there. And the question sort of becomes, what does it wind up looking like 6 months or a year from now? You have to kind of plan the strategy. But I think we're a long way from, categorizing necessarily the phenotype.
And, you know, Dan, you said you were going to ask me which 2 labs I would look at, and I want to interject and tell you which 2 and why. And I learned, you know, in my training, if you ask 12 endocrinologists their opinion, you get 13 different opinions. So it's
she'll give you the right answer.
No. So what I was going to say is, and you know, we all said this, I certainly will look at the hemoglobin A1C, and already knowing this patient, I'm going to anticipate that those triglycerides are going to be elevated, and I'm not very trusting of them because, as I said, 50% of the time, they don't think that, you know, if they drank orange juice right before they went to the lab that I'd ever know, or they just don't understand that, you know, how it's seen. So what I do is I look at the hemoglobin A1C, and if that asterisk isn't there, my eye goes to the LDL as the very next, you know, step, because I really want to know if I'm looking at, you know, a familial sort of hyperlipidemia in this patient. And that's what I think my focus is. And as Don said, the triglycerides may change if you check it every day for 10 days, you know, it may change. So while I certainly will note it, and that would be number 3, I feel like I'm not going to put as much stock in a long-term diagnosis by looking at that, but the LDL will be telling to me as to what I'm looking at in this patient.
Well, I'm going to play devil's advocate here, Parissa, and tell you that the LDL cholesterol is never going to be reliable in these patients. And I'm going to ask you to look instead at the non-HDL cholesterol or the ApoB.
Yeah.
Since even when they report an LDL cholesterol, chances are they're using the Friedenwald formula, and it's not going to be accurate enough in this kind of patient with elevated triglycerides. So I was glad to see asterisks only where the LDL cholesterol level was, rather than some made up number that doesn't really have a basis in reality, or has a weak basis in reality, I'll say.
Well, you know, and at some point, even though none of the 3 of us chose it, we're going to have to deal with the liver function studies.
Yeah.
Because they're clearly abnormal, but these are not unusual in this scenario. So the question sort of becomes if this is due to the type 2 phenotype, if I can use that term, and we see this all the time, right? But you still have to go through the gymnastics of the differential diagnosis. So you have to exclude acute and acute hepatitis and autoimmune hepatitis, and occasionally we see Wilson's disease and so forth and so on. So I mean, this kid's got diabetes, so you can burn out your pancreas. So there are a lot of things that have to be excluded. You could think about LAL-D, for example. But at the end of the day, and we do all those tests, and very rarely do we find anything, but occasionally we do, and it's important to know. The other thing is whether this child has a genetic predisposition for dyslipidemia, much as, you know, Lauren talked about multifocal chylomicronemia syndrome. So there's probably an element of that in a lot of these kids that we just can't account for. So I guess we, you know, could do some risk score if we had one that was validated in this population, but we don't.
So you know, we're really towards the end of our time, and so rather than going into a lot of detail, I think let's just say that this patient does not have a secondary cause beyond obesity and insulin resistance associated with fatty liver here. And that's what's causing the elevated liver enzymes. And maybe I'll just ask everyone to we'll wind up with this slide here, and let's just finish up with this. And I'm going to go around, and what I'd like is for you to just give us a sort of 1 minute, you know, what is your big picture and how are you going to, you know, forge ahead with the management of this care? And is there certain medicine that you're going to look at? And I'll set the clock ticking so that you get a minute. So Parissa, I'll start with you.
I mean, the most important thing to me is optimizing the diabetes care. And I think that's going to be a big picture of seeing the social dynamics, you know, doing the education, you know, nutritional education, and really just making sure that you're looking at all aspects of diabetes care that are involved. And so that would be my main focus.
Great, I'll take that. Lauren, you're off the hook for the medicine. You don't have to select the medicine, and since you're our dietitian. So
he's pretty good at it, actually.
What's your short and long-term goals for her?
I will say one thing, and it's not a medication, but this is not a patient that I necessarily would put on omega-3 fatty acid supplementation, particularly over the counter. I will say that. Because I agree. I think that optimizing the diabetes care, my 2 cents would be, especially with depression, I would try to pull in a clinical therapist, because from a nutrition standpoint, if, for example, what if she reported that she wasn't using alcohol, but really she was drinking? I mean, 14, it happens, and we've seen it. And so I think that really bringing in the clinical therapist to try to get those other pieces of the puzzle that we might be missing, but from a nutrition standpoint, really just trying to make sure that she has the overall knowledge of carb counting. We're doing it correctly. She has the tools on her phone in terms of apps and things like that, but then that she also has the help at home to make sure that we're accurately counting, we're accurately dosing insulin to try and optimize that care, and also getting complex carbohydrates rather than simple carbs too. So what is the quality of the carbs that we're getting? Got
it. And Don, I'm gonna give you the final word on this young lady.
Well, first of all, it's been a very insightful conversation. These are patients that we see very commonly and don't have all the right answers. But I think Lauren's correct, and that is the treatment of this patient actually starts with the depression and getting to know this family. And this child has to weigh in on what she wants to kind of accomplish. So it's going to start with her developing a problem list, and sort of for us listening to that and sort of saying, okay, if weight loss is really what you want to achieve, then let's talk about how you can do it and still manage your diabetes. I don't think we're going to correct her diabetes anytime soon. I think that's going to be a longer term agenda. Her dyslipidemia will bounce around, but I think it'll eventually get better. The question is whether her liver disease actually will advance, which would be an unfortunate situation for her. But I think you have to involve her in the conversation and see what she wants to attempt to do. One intriguing thought, I mean, so this is really a child with autoimmune insulin-dependent diabetes, if you want, in a phenotypic type 2 body. And so my guess would, having dealt with a lot of these, the first thing she wants to do is lose weight. That would also help all these other things. So the intriguing question is, would you ever consider, Parissa, would you ever consider using like a GLP-1 agonist in this child, even though she's got type 1 diabetes, or some of the newer experimental drugs that combine triple therapy and seem to have amazing results?
Well, given that it's in the news every day and parents are coming and, knocking down our doors, asking it, I think that has to be on the table. But I think, regardless, any individual that comes in with weight loss as a goal, you still have to work on the individual as a whole. So again, depression, lifestyle modification, all those things I think really need to be worked on more aggressively for, some time period before moving on to just the medical management, because that's just a Band-Aid cure if everything else is not really in place.
Right, and at least we kind of get too proud of our own ability to correct some of these numbers. If we corrected all of them and her A1C was perfect and she's miserable and doesn't like herself, or she's capable of self-harm, we've not achieved a thing, right?
Right.
We've actually done a disservice to it because we've looked the other way.
Right.
Yeah, so it's the harder climb, but I think it's the right thing to do.
Yeah, I would say, well, first off, thank you to all of you. This has been a great discussion. I've learned a ton, just in this short period of time. There's so many concepts that I don't think about all the time when taking care of adults. In reality, our adult patients have all the same issues. They probably have slightly better impulse control and a thicker skin to deal with the difficulties of all the things we talked about, but many don't. And it's very hard to have a big impact on the metabolic consequences of depression and inherited predisposition to medical conditions like obesity and diabetes, and expect our patients to just sort of roll with it and be accepting of everything we recommend. So I think that was part of the reason why I didn't want to focus too much on the details and the specifics of what drug to give, how much to give, and that kind of thing, and really just talk about the overlying theme of taking care of complex human beings with complex problems.
And then just one quick reminder, everybody who has a chronic illness, but particularly diabetes, is going to experience depression and non-compliance. And we shouldn't be critical of that. That should be just part of our understanding and empathy, because it's just going to happen. And to some degree, you can anticipate that and do anticipatory guidance. It doesn't have to derail people, but it depends a lot on their support system and so forth. So that's why it becomes important that you become embedded in that family, that you become a surrogate member of that family. You understand these people to the degree that you can, or they'll allow you.
Great. So with that, I will thank everyone for joining us this evening. And we are going to take a brief hiatus during the summer, and we won't come back with the next lipid panel until after Labor Day. So thank you all so much. And thank you to Dr. Ann Carol Goldberg, my partner in crime in the lipid panel, and to all you great panelists and for all the attendees.
Thank you. Good night.
Good night, everyone.
Thank you. Good
Thanks.
night.